So I'd like to welcome everyone to the second webinar in our three-part series celebrating International One Health Day. Thank you for turning out for this event, and I certainly hope it gives you some relief from the anxiety of election night. I'm Dr. Cassidy Rist, an assistant professor in the Department of Population Health Sciences here at the Virginia Maryland College of Veterinary Medicine. So the reason I'm starting off the session is because I serve as faculty advisor to the Student One Health Working Group, which is made up of about 12 students representing all three of our college's degree programs, including veterinary medicine, public health, biomedical, and veterinary sciences. So our working group also has student representatives from Virginia Tech Carilion School of Medicine and the Edward Via College of Osteopathic Medicine. So the purpose of the student working group is to host events and activities like this one that support communication, training, and learning across human and animal health professions. So in tonight's webinar, our panelists representing the medical, veterinary, and public health professions are going to discuss how COVID-19 has changed the work that they do and how it's affected the populations under their care. Our goal is to really dig into some of the unique technical, physical, and emotional challenges that individuals in the health professions face today, recognizing that there are likely going to be some shared experiences. Before I get too far, I want to make a note that we do have live captioning for this event. You can access it using the button at the bottom of your screen. And also please make a note of the Q&A button where you can submit any questions for the panelists. We will have time for questions at the end. So moderating tonight's session are Trish Haak and Dr. Jody Russon, who I am happy to introduce now. So Trish Haak received a Master of Social Work in Clinical Practice from the University of Washington, Seattle, following experience as a research associate for the UNC Chapel Hill Psychiatry Department. After graduating, she continued research project management at the Kaiser Permanente Research Institute in Seattle, Washington, and pursued a license in clinical social work. Upon moving to Blacksburg in 2014, she joined Virginia Tech's Cook Counseling Center to provide mental health services and serve as the assessment coordinator. During that time, Trish's passion for animal-assisted therapy inspired her to pursue the field of veterinary social work. Her current focus is on grief counseling, mitigating secondary traumatic stress, and client communication within the role of veterinary clinical social worker at our college. So outside of the hospital, she enjoys spending time outdoors with her husband, 2 children, dogs, cat, and chickens. Dr. Russon is an assistant professor in the Department of Human Development and Family Science at Virginia Tech. She is a translational researcher contributing to the fields of suicidology and clinical science. Community-engaged research is a fundamental role of her approach to science, practice, and education. Her line of research specifically focuses on the adaptation, dissemination, and implementation of suicide intervention and prevention strategies for community settings. Dr. Russon is currently working on early-stage research to develop a prevention program which addresses suicidality in the veterinary community. Thank you very much. And she has recently led an interdisciplinary effort to examine barriers and facilitators associated with the implementation of suicide prevention practices into colleges of veterinary medicine. So with that, I'll hand it over to you guys and we'll get started.
Thank you, Cassidy. So I'm going to first introduce Jason Deese, who's a MPH and a district epidemiologist for the New River Health District. Jason joined the Virginia Department of Health in 2017. He retired from the United States Air Force as a major in 2015 with 20 years of active duty service. Jason earned his MPH in epidemiology with graduate certificate in disaster management from the University of South Florida in 2002. Thanks for being with us, Jason.
We would also like to welcome Dr. Sofia Abraham-Hardee to the panel. Dr. Abraham-Hardee received her BS in biology with a minor in biochemistry from Bucknell University in Lewisburg, Pennsylvania. She completed a post-baccalaureate program from the Philadelphia College of Osteopathic Medicine. She received her osteopathic medical degree from the Edward Via College of Osteopathic Medicine. That was in 2007. She also completed her PhD in International Health Education from Virginia Tech in 2008. Dr. Abraham-Hardee completed her pediatric internship and residency at Geisinger Medical Center in Danville, Pennsylvania in June 2011. She is a board certified pediatrician and served as the medical director at New Beginning Pediatrics in Blacksburg, Virginia from 2017 to 2020. She is currently Department Chair of Pediatrics and Associate Dean of Clinical Affairs at the Edward Via College of Osteopathic Medicine. She was awarded the Golden Apple Award in 2014 to 2015, as well as in 2018. And Dr. Abraham-Hardee was also awarded 2013, 2017, 2018, and 2019 Best Bedside Manner in Our Health magazine. So welcome to Dr. Sofia Abraham-Hardee.
And I'd like to also introduce Dr. Courtney Wiegard. Born and raised in Waynesboro, Virginia, Dr. Wiegard received her Bachelor's of Science from Denison University in 2001. She received her DVM from the Virginia Maryland College of Veterinary Medicine in 2005. Dr. Wiegard began working at Vinton Veterinary Hospital in June 2005 and became an owner of Vinton Vet in October 2019. She then became an owner of Pet Vet Roanoke in January 2020. She is married to her wonderful husband, Spencer, partner at Gentry Lock Attorneys. They live in Roanoke with their 2 daughters, 4 dogs, 1 cat, and 1 guinea pig. Thanks for being with us, Dr. Wiegard.
We have a wonderful panel here today to talk about this very important topic. And so to start, we have some questions for you that will help us get a sense of your work and the evolving landscape since COVID-19. And we'd like to hear from all of you. I would like you to tell us a little bit about your typical workday at this point in time. So whoever would like to begin, go ahead.
I'll go ahead. So I'm Dr. Wiegard. Again, thank you for having me tonight. I'm a general practitioner of companion animals. So we see mostly dogs and cats. We've recently started seeing some exotics. I have 2 clinicians who are seeing exotic patients now. When COVID hit, we were very worried with the economic turndown that people would stop bringing their pets in. That they would hunker down and not come out. But what we saw was dramatically the opposite. Our workload doubled and tripled. People were wanting, their only outlet was to come to the veterinary office. So we had to staff up. We had to put on our masks. We decided to do a curbside service. So no clients in the hospital unless they were there to have their animal euthanized. Then we would allow them to come in. But started this whole process of, we call, we get information, technician goes out and gets the patient, brings the patient in, the doctor looks at it, doctor calls, patient goes back out. So the inefficiencies of curbside have been daunting. Appointment times have doubled, but the demand has also doubled. So my big hospital, Vinton Vet, is an 8-doctor practice. My little hospital is about a 1.5 to 2 doctor practice. So what we found with our big hospital is that the little hospitals around us decided not to take on new patients or clients. And the emergency clinic wait time was between 3 to 6 hours. So we became an urgent care. So not only are we seeing wellness appointments, but we're now taking on emergencies that do not want to wait at the ER. So it's exhausting. We are running. It's inefficient. Our phone lines do not stop ringing. They're constantly busy. There's a lot of burnout. My staff, a lot of anxiety just with even having to go face-to-face with clients out in the parking lot. The client frustrations have doubled and tripled because of our inefficiencies, and they want answers and they want it now and they can't get through the phone line. So, we see wellness, but we see a lot of emergency urgent care, and we've had to completely staff up and take on the burden for us, our surrounding areas where other little tiny clinics just can't keep up with, or just decided not to, shut their doors and said, we're only going to see our patients. Nobody knew. So it's exhausting. My doctors are tired. My staff is exhausted. And then we always have 1 to 2 people out either for possible COVID or COVID exposure, or the house, if somebody in their house has COVID. So we're always 2 to 8 people down in a small hospital.
And it sounds like the work has quadrupled, not
Yes.
just doubled, but quadrupled. And it's incredibly stressful. And I'm wondering, Dr. Abraham-Hardee and Dr. Deese, how are your experiences similar or different? I know you work in different types of settings here, so I'd like to hear your perspectives as well.
Jason, do you want to go? Okay, I'll go. So I'm a pediatrician, and thank you for having me on this call. I will say my experience is very different than Dr. Wiegard. Starting COVID, I would say in March, when everything came to full fruition, people didn't want to come to the doctor. We had to, and they would call with like life-threatening issues or high fevers in kids. And in our clinic, we see 0 to 21. And they would just want us to treat over the phone. And it's, it's a fine line between, keeping your patient satisfied and doing good medicine. And, again, that frustration, that piece of frustration is something I can definitely see as well, what Dr. Wiegard was mentioning. But our patient volumes dropped significantly. I think in the last 2 to 3 months, we are slowly picking back up. People are, I think, needing an outlet, and coming to the doctor is like it's like a field trip. Kids dress up, parents come, and even though we want to say, hey, just one parent, their whole family wants to come. So we entertain that, and I think most clinics have the same policy. You get screened when you call to make the appointment, at least a week before, and then you get screened 2 to 3 days before, because we know with COVID, your symptomatology might change completely. If they are positive or they have traveled to another state, we do not see them, which is unfortunate. Then they have to be switched to a telemedicine, which is still not ideal, right? Sometimes you do have to put your hands on your patients. But if they do come in, one parent with one child, they have to wear a mask. All the screening is done ahead of time. They wait in the parking lot, they call. When our nurse is ready to room them, they meet them at the door, and they get taken back into the triage room. And then we have a sick hallway and a well hallway. With our sick hallway, there used to be 2 separate hallways. Now it's like on the other end of they have a completely different entrance, just because you could have cough and it could be just allergies, but you're deemed COVID positive until proven otherwise, right? You could cough in the grocery store and people look at you like you're crazy. So I think everybody's just so heightened with these simple symptoms that could be allergies, could be, I just have a migraine, So it's just changed medicine for us. From a flow standpoint, it has made things like just some irrelevant steps for the future, but very relevant in the midst of COVID, but it has made things a lot harder, and the flow it took some getting used to as far as our staff. But I think now all of us have the groove, and I hopefully, considering COVID's not going anywhere anytime soon, I think we have a system in place.
So your experience has been different from Dr. Wiegard's in that your volume has shifted over time and is now on the upswing, and you've organized your processes around that to try to make it work in the best way possible. Dr. Deese, how has it been for you?
Okay, I'm unmuted. So yeah, life in the health department. It's been a crazy year. And I've got to say our volume certainly has increased significantly. Starting in January, from the very beginning of this thing, before we even had cases in the US, of course, we started planning, preparing, dusting off the flu plans, because that's what we based all of our COVID stuff on, was, the previous flu planning, and digging through supplies to make sure that we had PPE and stuff like that. So it all started in January. I haven't had a real day off since January. In fact, I had an endless stretch of weeks between 80 and 90 hours a week, taking calls constantly, day, night, whatever. And believe it or not, things have started to calm down a little bit. Even if the volume has remained kind of stable, we do have more staff dedicated to COVID-19 now. And so my daily grind consists of getting up in the morning and having my coffee. And usually I've got multiple emails and texts waiting for me by the time I wake up. Sort through there. Sometimes I ignore them, to be quite honest with you. It's a survival tactic. What's important, what isn't. If stuff can be solved either by thinking, by looking it up, or passing it off to someone else, that'll be done. And I hate to sound that way, but that's the reality of it. These are ways that we figure out and focus on the important things. So my daily grind is a lot of triaging what's important, what isn't, delegating stuff to people. We usually have all of our caseload for the first half of the day out by 9 o'clock to our case investigators. We have like an army of case investigators and tracers. And so Erica Short and I, primarily her in these last few weeks, kind of quarterback getting the caseload out to the case investigators and kind of controlling things as they go, make sure that they've got adequate workload, but then we're on standby to answer any hard questions that they have. Also, if they notify us of an outbreak and all that stuff, there's stuff that happens up in Richmond that we have to notify them, and a lot of answering. I guess not so much me anymore. I was the sole COVID guy into, I guess, March timeframe. Right. And so anything COVID that hit the front desk at the health department was relayed to me until it just became unbearable. Absolutely became unbearable. So we do spend a lot of time as a team addressing community questions, complaints about businesses not complying. School stuff is big right now. I'm in the midst of a whole bunch of nursing home cases and outbreaks. So every day is a little bit different, but one thing is for sure, that we have a lot of work. So there we go. There's a typical day for me. Starts sometime in the morning and ends sometime at night. And glad I have help.
The demand is very high right now for all of you. That's what I'm hearing. Things are changing and the demand is high. For some of you, it's been steady. For others of you, it has waxed and waned, but it certainly sounds very challenging. And in your answers, I really appreciate how you gave me a sense of the processes that changed, as well as how your lives have been impacted by COVID-19 in the workplace. I'm curious to hear how you see health and medicine changing in the future as a result of our current COVID-19 challenges. So I know you are in the midst of it right now, but do you see this shaping health and medicine in the future?
I'll answer that. I'll start off. So I think two things popped in my head as far as, the positives moving forward or how it's going to change future medicine for humans. One, I think, is the use of telemedicine. This day and age, there's no reason why clinics should not be using telemedicine, but I think it should be at the discretion of the physician or the staff and the parent involved as to when is it appropriate to do telemedicine. If you want me to see a rash, telemedicine is just not ideal because I can't touch it, feel if it's hot. I mean, there are some limitations to telemedicine, but there is a time and place for it. We use telemedicine for our 9-month checkups where they don't have vaccines. We just saw them 3 months ago. We're going to see them again in 3 months. So as long as parents are reliable historians, they're trustworthy, there were no concerns at the previous visit, and parents say everything is going well, we give them the option to make it telemedicine. And hopefully insurance companies, again, being a big limiting factor in most things in medicine, hopefully they'll recognize that, because we have some patients who drive an hour and a half to come see us. So if we can give them some relief in things such as that, or if it's just an ADHD follow-up and there's the main caretaker is ill, we should be able, it should not disrupt their medications just because they can't physically come into the clinic. So telemedicine, I'm hoping that that will continue as a resource for the future. The other thing is, I think, just being appreciative of viruses and how they transmitted. Flu has always been around. And, people say, oh, the flu rates might go up, and they might. But I was like, think about all the precautionary things we're doing. We wash our hands every 5 minutes. We have face covering. We're like 5 feet away from, 6 feet away from people, right? So the chance, just common hygiene things, hopefully it'll become part of our habit. That it will decrease rates when somebody is sick. How our kids, they're getting these habits of good hand washing, staying home when you're sick, recognizing how easily certain viruses can be transmitted. So I'm hoping just general public education, I think we've become more aware of these concepts.
Telehealth and general public education. And I'm curious, Dr. Wiegard, the telehealth perspective from veterinary medicine and what you're seeing here.
Yeah, I mean, there are a lot of places that took advantage of telemed, and I feel like we've been doing telemed forever with these phone call conversations that we have with clients that just don't want to come in. Can't you just give me something? Can't you just well, I really should put my hand to your dog. Can't tell me what they're doing, how they're feeling, what that lump feels like. But some of the bigger cities that went on very strict lockdown, like New York, some of Atlanta, some of the other places, people couldn't leave their house. And then if you've got a COVID positive patient that's quarantined, telemed was very big. And I think there are some bigger city, DC, New York, Atlanta, bigger cities that are still utilizing telemed. It just didn't work for us. They just kept coming in the parking lot. And so I think what's changed for us, I think, yes, we'll do some telemed in veterinary medicine, but I have the Starbucks moms who could not be more thrilled with curbside service and would prefer to never get out of their car again and have their dog valeted in with the little carrier and the pocketbook or whatever they need to do. They don't have to get out of the car. They love it. And then we have the other contingency that is like banging down our doors. Let me in. I'm not coming in there without my baby. So those clients, they're upset and they're ready to come back in. But I think that curbside may be an option going forward for the veterinarian. If a person doesn't want to come out, or they're scared to come in, we now have the option to, okay, we'll come get your dog, just help us get it out. And but also with the hygiene for my staff, it has been huge. Washing hands, cleaning off doorknobs, not coming in when you're sick, because if you get a positive person in a tiny little department, it'll wipe out a whole section of people just for quarantine purposes. So it has, I agree, it has changed everyone's perspective at my work as far as their own personal hygiene. But I think, telemed, I think will be part of the future of vet med. But I think the curbside thing, unfortunately, some people really like it. So it's going to stick around a little bit.
Dr. Deese, any thoughts from you about how you see health and medicine changing in your field as a result of COVID?
In my field specifically, and I'll probably touch on this if we're going down the punch list of questions, is that epidemiology was a rather obscure profession before COVID-19. And now a lot of people have learned through Facebook and, legitimate news sources or whatever about the career field. So there's a lot of attention on it. There's a ton of armchairing. I can see every outbreak in the future being armchaired by Facebook certified epidemiologists and others who proclaim to know what they're doing. So that's one thing in the age of social media. This is the first real big one that kind of blossomed in the midst of all this. And then you throw into politics and everything. That's a different topic entirely. But what I see is that, on the good side, the public has learned quite a lot about what, for example, an epi curve is. They've learned, as was previously mentioned, about viral transmission, things that we as professionals kind of have taken for granted that people know that respiratory viruses, go from person to person, and how to prevent that. Some things that are effective, some things that aren't, stuff like that. A lot of this is ages old knowledge that's been lost for some reason, stuff that epidemiologists and doctors knew 100 years ago about respiratory disease transmission seems to have been somehow forgotten, and now remembered again after 10 months of rehashing old research to mask work, they don't, that type of stuff. So I would say from my perspective, the public attention going forward on every outbreak that occurs will be probably very high, and we're under an extreme level of scrutiny, as of course. And it was never political until now, though, and that's a strange thing, and I kind of see it continuing, unless I'm just naive about past outbreaks and the political nature of things. But this is the first one that I've seen being driven by non-scientific sources from both sides, not just from the right, but also from those on the left who have gone a little bit nuts too. So I guess that's all I got to say about that. And I don't see future outbreaks, that whole hysteria side. I guess Ebola, maybe there was a bit of that with, I don't know. Now I start rambling. So there we go.
Thank you for that perspective.
So each of you touched a little bit on how things have evolved over the course of the pandemic for you. I'd like to ask you some questions about communication in particular, because it sounds like some things have changed, some things have stayed the same, maybe just in different ways. So if you could kind of dive a little bit deeper into how the communication has evolved throughout the course of the pandemic, and think about, the challenges or the rewarding parts of the changes, or the pros and cons, just what the experience has been like for you.
Well, for us, because our way of practicing has completely changed from curbside to the face-to-face. So, I rely completely on the client and human to bring their pet to me. I can't do my job without the human aspect of it. So for me, one of the reasons I became a veterinarian was that not only the human animal bond, but the client and veterinarian bond. So to not have that face-to-face for me is really difficult, to the point where if it's not pouring down rain or ungodly hot, I march outside and go to their car and talk to them face-to-face. That is a big complaint that we have received from clients, is, well, I didn't even get to see the doctor. I didn't get to, I'm missing that bond with the doctor. And so there's such a level of empathy and compassion associated with my profession, that to not have that face-to-face bond, clients just are not having it. And really, unless you're an extreme introvert, and this is like the best thing ever, to never have to see a client ever again. For us extroverts, or who need that bond, it's difficult. So kind of had to have like a heart to heart with my docs and say, we got to get up out of our seats. We got to go outside. You need to introduce yourself. We've seen a huge surge of puppy and kittens, adoptions, shelters getting just, everybody's getting adopted out. They're clearing the shelters. So we're getting new patients all the time. And those clients haven't had an opportunity to bond with us as veterinarians yet. And for us, that's a huge part of building our practice, because we see them from, infancy all the way to geriatrics to death. We're one of the only professions that gets to see that entire lifespan of our patients. So for us, it is, okay, we want to talk on the phone, but you know what, I'm gonna put on my mask, I'm gonna go outside, ask the client to also put on their mask so that we can have a face-to-face and I can see them and look them in the eye. So even though we're curbside, we get up and we go out, because we just don't have that bond. We can't do that over the phone.
Wow. So it sounds like you've been very intentional about maintaining that ability to build rapport and develop that relationship, despite, what we're going through. How about Dr. Abraham-Hardee and Jason? What have your communication challenges and pros been?
So I would say communication has taken different avenues. I think in the past, for our elderly caretakers, right, grandparents who are, the sole custodian of the kid, they were like, oh, I don't do computers, or I don't do, it's the phone call, right? It's pick up the phone, it goes to our nurses. And I think now, because they rely on telemedicine, all of a sudden everybody's on the portal. Through our electronic medical record, we have a portal where they can send us a message through the patient's chart directly, and it comes to the physician. So it totally bypasses the nurses, which is, our nurses are already overwhelmed with the number of telephone visits and triages that they have to go through. So it does take the load off our nurses, so a patient can directly send me an email, which goes and is saved in the patient's chart. So all of a sudden we are seeing these people getting more savvy with high-tech stuff, which is good. It's not like it's a end all be all, but it is just other avenues where they can contact the physician, which is wonderful. Another perk, I think a lot of trust had to be built between, just like Dr. Wiegard said, that bond between a physician and the patient or the caretaker is so important, right? We trust the information you give us, and hence we move along our medical algorithm based on our physical exam and the history provided. I feel it's caused people to build that trusting relationship even more, just because when I do a telemedicine, I'm relying on the caretaker to, touch something. And it is so important you tell me the truth, right? Don't fabricate, don't tell me a fever that was one day that has gone on for 10 days, because my plan will completely change, right? So I think giving the caretaker more the ownership of the history and, coming in. And because people are so fearful to come into the doctor's office, I feel like they are trusting themselves with saying, okay, I can handle a 6-month-old with a fever, 1-day history of 100.4 fever. I think I can do this, right? So I think it's causing parents to have more trust in their own skills, right? Once they talk through it, they go through the risk benefit, what are some red flags to watch out for. So I think overall, trusting their own skills and trusting the physician as well.
Wow, that's really interesting. So it sounds like people are becoming more savvy and definitely embracing the technology across generations. And that's wonderful. And maybe it's creating some efficiencies in communication and relationship building too. How about Jason, in your world, communication? I imagine that there's just embracing technology is just at the heart of what you do.
Yeah, so the good news is my MO has always been using the phone primarily. It's efficient when you're calling people up. When you've got a long list of people you got to communicate with in a space of a work day. Depending on the outbreak or the situation, I used to make field visits, go in and lay eyes on a situation. Sometimes laying eyes on a situation actually helps you, solve a mystery that you're trying to solve. But with COVID, there's not a whole ton of that. I could show up to workplaces and look and see where the index case is and point to, okay, you need to test this person, this person, this person, this person, whatever. But to drive out there, 20 minutes to drive out to the, workplace, do the assessment, come back. During that time, I probably could have dealt with, 5 or 6 additional people. So I've always, preferred to do things over the phone, even in different types of outbreaks. If I'm doing a Legionnaire's outbreak, I've got no choice but to go out to the facility in question and actually, investigate. But with COVID, you don't have to, because it's a respiratory, virus. We know how it spreads. I've got a decently vivid imagination, so I can imagine the layout of a cubicle farm or a factory floor or a schoolroom or whatever. So my modes of communication really haven't changed. I can say, though, that as far as effectiveness of communication, with the volume, just the volume, and I've been doing this for years, but the volume of calls, the repetition, encountering similar situations over and over and over again. And I'll use, college students as a fine example. My day back in September wasn't complete unless I was on the phone with a 19-year-old girl who's crying her eyeballs out because she just got positive results from COVID, right? So I got really, really good at talking them down. And the goal was always to make them laugh before you hang up the phone, right? So, and sometimes guys cried too, I should be fair, less often, but sometimes they did. You know, we had one guy that called back repeatedly 5 or 6 times, just bawling his eyes out because his girlfriend broke up with him because he got COVID. It's just crazy stuff. And so there's a fair amount of psychology. There's a fair amount of the anthropology involved as well, figuring out, you know, because we do have people from multiple different cultural backgrounds that we're dealing with. The Latino population was hit really, really hard back in the summer. And so just learning a little bit about the way that they're living and working and everything was helpful to improve communication. And obviously we're doing a lot of this through interpreters, but you know, and then there's the public communication side of things, which is a huge part of the job. Just, you know, news people calling me up wanting me to talk to something or other, like having a safe Halloween. Didn't think about it as an issue. Still don't think about it as an issue, actually. But, you know, did a news spot last week on safe Halloween. Just don't get in a crowded room with people. Your costumes aren't going to protect you. So there we go. Lots and lots of public communication, lots and lots of individual communication with people that are very, very scared and upset. I think scared and upset are the two biggest things that, you know, the mass media did a really, really poor job, or depending on which way you look at it, did a really great job at scaring the crap out of people, quite frankly, about how awful this disease is. And I got to tell you, this disease is really awful for a very small subset of people. And most people otherwise are well. We've done 4,700 cases as of today in my district, and the vast majority, 99.99 something percent, do just fine without being hospitalized, without dying or whatever. And so that piece, reversing some of the psychological damage done to people back in January, February, and March, has been probably the hardest part of it. And that's reflected directly in the 19-year-old girl who really has no risk of going on to a severe disease, bawling her eyes out, you know, wondering if she's going to live or die. So some of that communication.
Yeah, it's all relative to the individual's experience and so many factors that they bring. It's brand new for everyone. So I'm curious to know, you know, your communication you're talking about on many different levels. There's the public and there are the individuals. How about communication with your coworkers, your peers, your colleagues? You know, we're having to do everything in a different way right now. And I imagine that just, you know, getting information from place to place is sometimes challenging. Can any of you speak to your experience with that?
So I'll chime in. And so my experience being in the clinic setting, so we are teaching clinics. So we do have third-year medical students and a family practice resident rotating with us. So we always have at least 3 to 4 learners in addition to the pediatricians in the office, in addition to the staff, the front staff, the office manager. And these students, 4-week rotations, they go to their next rotation. So I have no idea what risk profile they're coming in with. Obviously they're asymptomatic, they're screened and all that stuff. So there's that constant revolving door with our learners. But they wear their full PPE, you know, as they go. They're not allowed to see high-risk COVID patients just because they might be going from peds to ICU, where there is a high-risk individual that they'll be taken care of. So we do risk stratify in that respect. And they wear, you know, their N95, their goggles and gowns. If they're seeing any sick patients, well visits, they have to wear, you know, their mask with every visit. I think personally, it's caused the team, because even though you've not actively seen a patient, you can learn from the discussion, right? The pediatrician asking the student or the presentation or the differentials. So I think we're all still sitting in the room, but we're talking over these masks, right? It's almost like a barrier to communication, right? We're speaking up, or, I have to step out because I just need to breathe without my mask in the bathroom for a few minutes because I'm getting a headache. And some pediatricians are more comfortable, if there's downtime or they're charting, they don't sit in that communal area where we all used to sit, they're back in their offices. So I think it makes communication, a little more distant, even though we're all physically there. From the medical school standpoint, meeting, so I run the clinical chair meeting as associate dean. We all used to sit together, have lunch together. Now it's over Zoom. Right. And it's just, as I think one of the panelists said, we are social beings. We love to be around people, right? Especially the professions we've chosen. We love to be around people. And it's just simple examples like meetings over Zoom. I was like, it's almost getting tiring to be on a Zoom meeting. Like, you just want to see people face to face, right? You want to shake hands. You want to give people a hug. Like when I have a student who comes in and is like struggling with their grades and, bawling why they got a C on their end of rotation exam, you can't just comfort them the way. You have to keep that 6 feet distance. It's over Zoom most of the time, right? Because if they're on a rotation, they cannot physically come back in the building. So just communication on so many different realms have added challenges. I feel like we are becoming very distant. And hopefully, I don't think we'll stay that way because innately we are social beings. And I think, Dr. Wiegard, you said if you're an introvert, you're great, right? This life is good. But for extroverts, or people who love that social connection, even introverts, right? They still love to be around people, but in small sections. Like they pace, they control the interactions that they want, right? But I know personally for me, I enjoy being around people, and it does become challenging. In our office setting, we still expect certain people to be there. We kind of rotate, so we're not all there at the same time. But since there's a presence in the clinical affairs office, we kind of rotate through. So it's nice when one day all of us are there. We're like, oh my gosh, we're all here. We're all in our offices with our masks, but at least we're physically in the building. So it's just nice. It's almost like human interaction is becoming a rarity. But hopefully with time, like, that'll open up as COVID, like, we are in a better place.
Right. And we're adapting, and it sounds like finding new ways to communicate or using existing ways. Jason, you're talking about the phone, just picking up the phone. It's the most efficient way to communicate right now. But yes, those nonverbals, they're really important. But I love that you continued Zoom lunches, even when you couldn't be together. You just business as usual. We're going to do this how we can. Other thoughts?
I totally agree with Dr. Abraham-Hardee. I mean, we, in our veterinary office, it's very hard to social distance because the doctor needs someone to hold the animal or to get a blood sample, or we are all over each other all the time. So the hygiene, the mask, and it can be daunting. And sometimes I feel like I can't see with my mask on, and I'm tripping over people, or I'm like, I can't hear you. And, and people's instinct is to pull it down to try to talk, and so you can see their mouths talking. But we find it particularly hard because we are so close to each other. We're holding animals for radiographs or x-rays. We're, again, restraining animals to get physical exams or things done. So that has definitely been a challenge. But for us, we've all had to be there all the time. So we've been all over each other, just praying that everybody is behaving outside of work, and, please do your due diligence. We can't control what you do outside the office. We can tell you what to do here, but we beg you to just please be smart so that we don't take out an entire department, or, but the other thing is to not shame somebody if they get COVID. And so I think for us, it's we have people out from time to time who are being tested, around somebody tested, and trying to tell our staff, like, it's, they're okay. It's not their fault. We're not mad at them. Yes, we are all now having to work the job for 3 people, but you can't be mad at that person. It's really not their fault unless they were just being silly. But trying to get past that stigma, like Dr. Deese was saying, of don't freak out. Like, we're all healthy people, and we know people with autoimmune conditions or whatever, but for the most part, everybody just needs to not go down the rabbit hole of what could happen, and just try to be positive. So I think for us and our staff, is just always trying to maintain that level of positivity when everybody is having anxiety over the workload that we've taken on, but also just trying to keep ourselves safe, knowing that we're interacting with clients and each other constantly. It's hard. It's been hard. The up and down, trying to be the cheerleader all the time is exhausting.
Absolutely. Yeah. Dr. Deese, any final thoughts on the communication piece?
Yeah, and internally, I'm glad you brought that up. Internally, I think this has been a great exercise in team building. We've learned a lot about each other because we're spending a ton of hours together. And we do hold face-to-face meetings. Our leadership team over in the health department, it's super efficient. We distance and wear our masks, and we do think it's important to hold face-to-face meetings at least once a week. And with my case investigation and tracing team, we were meeting weekly while they got spun up and improved their skills. And now we're meeting every other week in person. And I think there's something to be said about everyone being in the same room. Someone mentioned the nonverbals. 20 years in the military and leading people. I've learned to read people and their level of morale by looking around at the table, looking at their body language, looking at, now you can't see their faces when they got their masks on or whatever, but it is helpful to touch base in person and have that interaction, because as a leader, and by the way, I took this job 3 years ago as my retirement job, and I didn't have any responsibility other than to my patients, right? I wasn't supervising anyone. We created ad hoc teams as needed. And now I've got this large team of people that I have to lead again. And so communication is super important. I've had to dig deep because I was out of that frame of mind, but it's important when you're a leader to be able to show strength and show integrity and show work ethic, but at the same time have that empathy for them, because we're all working really, really hard, right? So sometimes that's a tough balance to have empathy with them, but at the same time tell them, shut up and color. We got work to do. We're behind 40 today. Let's go.
That sounds like a perfect recipe for community resilience right there. Everything that you've pulled together from your life is just culminating right now in one way.
I wanted to follow up with you, especially with regard to the last point of being able to be a leader during this time. We've been talking about burnout in the healthcare professions and medical professions for a very long time before COVID. And now that COVID has happened, there is renewed interest and effort centered on understanding burnout and what folks are going through. And so I'm wondering if you all would be willing to talk about how you're managing burnout in your workplace. And to Dr. Deese's point, you're not just for yourself, but for those that you lead. So if you could share some of that with us, it would be wonderful.
Oh, I'll speak up, because I don't think I've cried more in my profession than I have in the last 10 months, but trying to keep it together. And I'm sure Dr. Abraham-Hardee is the same way. We, as a leader, you have to stay strong and keep the morale up. But there are times when it's overwhelming. And so I joke around that, exam room 5 is the perfect place to cry. Anybody just put a flag out and let people go. And I've tried to encourage my staff to, their emotions are valid, their feelings are valid, and we're all stressed out. And my poor family, unfortunately, I have the best family in the world, and they have really held my hand and kept my head up, because I can hold it together when I'm at work, but when I get home, I'm exhausted physically, mentally, emotionally. It's a lot. And so trying to put out fires every day while still seeing patients, while still trying to be a medical director for a hospital and manage people and keep my other 7 veterinarians, keep their morale up and keep them going and try not to let them get burnt out. It's a lot. I'm not going to lie. It has been, there's been a lot of anxiety. So things like this, conversations like this are extremely important. And I hope that other people will, again, finding the time to get help is a whole nother can of worms, but just having each other to lean on. I know there are a lot of Facebook groups. There's one on Facebook that's called Not One More Vet, which is a really good one for veterinary suicide. And there's moms with a DVM. There's all kinds of support that people can have and reach out to. And I hope that our colleagues, and maybe this will be a great way to reach across the table to the human healthcare and to the public health, and know that, you know, we are all in this together. And we really need each other. And I'm going to need Dr. Abraham-Hardee with one of my children, or I'm going to need to call Dr. Deese and say, oh my gosh, I've got a positive in my one little department, and what do I do? And so to have that rapport with each other and know that, you know, they're just as stressed as I am, and it's not all about us, but we're in it together, I think is really important. So this for me has been wonderful to hear different perspectives on what other people are going through, because you get so focused on survival in your one little world, in your profession, that it's nice to see or hear from other people what's going on.
Thanks for sharing that. I mean, it sounds incredibly overwhelming from the way you describe it, and from what you're saying, the way that you mitigate that is by connecting to other people. And we need to do that within our professions and outside of our professions. So I appreciate you sharing that. Others' thoughts about managing burnout, and not just for yourself, but as a leader.
Absolutely. So, you know, pediatricians brag that we have the least burnout rate out of all subspecialties in the human medical profession, because, I mean, we take care of cute kids all day, every day, right? So, I mean, if you think about it, like pediatricians, they're taking care of 3 generations. They're like, oh, the grandmother was my patient, you know, and they're still practicing. But even in the midst of all of that, right, the burnout, I think, is coming from what was the norm is no longer the norm, right? So you've been practicing for 20, 30 plus years, but now everything is changing, right? Which change is not easy, right? Change takes time. And it is, you know, you have people coming in, like with my patients, a lot of anxiety, right? In patients that were well controlled in the past, grades, like, you know, there's a high risk individual in the household going to school, and then now the kids' performance is, you know, slipping. So I think there's turmoil in so many aspects of a household, you know, for multiple reasons, right? Stress from parents who, I cannot afford to keep my kids home because I need to work, even though inside the parents feel guilty for sending their kids to school, right? You know, there's a hierarchy that, oh, you know, if you stay home, you're safer. But is it, you know, physically, okay, you might not get COVID, but mentally, what is your kid looking like, right? So I think, you know, when people ask me, Dr. Hardee, what should we do? Should we go to church? Should we go to this? Should we do that? I said, you know, it all comes down to what you need to self-evaluate your family risk stratification. What are you comfortable with, right? My answer might not be your answer. What I decide for my family is very different. I think from coping standpoint, I think it has been hard for my patients, their families. But I think what has gotten me personally as a leader, as a mom, as a pediatrician is the support, right? You know, you're absolutely right, Dr. Wiegard. If it wasn't for my family, my daughter, my 10-year-old daughter, she says, Mommy, come back with a better attitude than you left. You know, she always, every morning when I leave, like, you know, it's always about coming back with a better attitude than you left, because we have the power to impact many people we come in contact with, right? Whether it be a nurse who, you know, is struggling to find a babysitter for her kid because the babysitter got sick, right? I was like, there's concept, we have to be so supportive of each other. For single moms, you know, families that, hey, I can't cover today because my kid has to go to the doctor, right? And usually they would take off, but these circumstances are different, right? And, you know, the quarantine period, hey, you're gone for 14 days. It is what it is. We all have to step in and support each other. So I think it's called us to call on our families, call on our community, our colleagues, and say, it's okay to ask for help, right? You know, I'm struggling, and it is not a sign of weakness.
So important. We often don't get the support we need if we're not asking for help. And so what a clear and important message that you're sending. Dr. Deese, how about you?
Right. And I probably should have said this earlier, that I'm not a doctor, so I don't want to disparage real doctors by me being called a doctor. You know, I didn't earn a doctorate, so my apologies for not clarifying that earlier. But anyhow, yeah, burnout's a very real thing. I'm surrounded by burnout. Some might say I'm burnt out myself. I might say that. You know, burnout management, I've been through this many times in my life as far as, you know, sometimes voluntarily biting off more than I can chew. And I've learned the hard way that you've got to be able to personally pick what's important and what's not. And, you know, as hard as it is to say, sometimes I do have to leave work on the desk, and sometimes I do have to encourage my subordinates to leave work on their desk. You know, pack it up. If I'm packing my backpack up, you pack yours up, because this is it for today. We're done. That said, I think it's an important thing for people in leadership positions to be among the last to leave consistently. Now, I do have a family, and I've got to balance that. I don't want my kids to grow up screwed up because dad's gone. And so I do try to strike that balance as much as I can. If that means sometimes working from home, you know, during a weekday on that occasion, so that I can have more interaction with the kids or whatever, sometimes it goes that way. But yeah, I've had people quit, straight up quit. It is what it is, or everyone has their threshold of what's burnout. And if I can prevent that, I'll do my best. At the same time, we've got to meet, you know, the public's demands for what it is we do, and we have to take it seriously. So there's that happy balance of being able to be in it for the long game. And if you're going to be in it for the long game, you can't work 80 to 90 hours per week for weeks and weeks on end. And I did that for several months, and, you know, quite honestly, can't do it anymore. And I'm encouraging my peeps to, you know, manage their hours and manage the way that they work in ways that they can get things done more efficiently as well. And if that means cutting through bureaucratic red tape pushed down on us from Richmond, you know, if anyone from Richmond is listening here, you know, you know, my weekly teleconference with Richmond, I remind them that they're in Richmond and they're not in the field. And some of the things they're asking us to do are rather ridiculous. And some of the metrics that they're throwing out there are nothing but extra work for us. And, you know, so some of the things that they're asking our tracers and investigators to do during their investigations, questions to ask, they add on 3 to 5 minutes to an investigation. Yeah. And I've got to defend my people the best way that I can to prevent them from being burned out. I've got to assist them in being efficient with the workload so that they aren't burned out. So that's the position I see myself in now, is just doing my best to keep things as efficient as possible so people can have something of a life, and maybe one day a week on the weekend or something.
And I hear you trying to strike that balance of being able to model, we need to go home, we need to take care of ourselves, and at the same time meeting the demands from Richmond and meeting your own demands as a leader in the organization. It's a lot. It's a lot that you all are managing here. And Trish, I want to turn it over to you.
Yeah, that balance that you're talking about. You really articulated that well. And I also just wanted to highlight that you said you literally forced yourself to kind of leave it and go. I think that's a very important point. So we have a Q&A question from attendees. One question is, I'm curious on if there were clients / patients / cases / contacts who did not want to follow safety guidelines, and how did you deal with them? And anybody, feel free.
I mean, we have people pound on the door. We've had people scream at us in the parking lots, you know, refuse to put on a mask and we won't let them in. We get nasty survey results, reviews that we wouldn't let them in the building with their animal. It has gotten ugly. I mean, people's literally screaming, honking at you in their cars. don't understand. It's kind of died down a little bit. I think more towards the middle of the pandemic when people they've got pandemic fatigue and they just don't care anymore and they want to come in and they're going to demand to come in, and we have to stand our ground. We have to defend my staff. These are our protocols. We're trying to not only keep ourselves safe, but keep you safe as well. And so our exam rooms are tiny. We can't socially distance and we're already tight. So we just have had to literally just stand our ground and adhere to what our policies are and kindly ask them to move away from the front door they're pounding on. And then we'll get to them as soon as we can. And we've taken a lot of heat. And we just have to take the good review, the good positive surveys with the bad and know that in the end, we're doing the best that we can. And that's all we can do.
I haven't had a lot of nasty personal experiences because I think most of them are coming with their kid right next to them, right? And most people want a safe face for their kids, which is wonderful. So we usually get them on their best behavior, I think. One of the things, I usually teach by example, right? So the mask is like here, it's like, I usually tell the kids, and oftentimes kids, it slides down, it's not the right size. So I always say, hey, it's a teaching moment as far as, hey, why it's important to wear a mask and why wear it correctly. Oftentimes the parents will, it'll be around their chin. And I understand they're waiting for me in the room and, they're with their kids. So it's probably, and they forget to put it back up. I'm hoping it's not out of, I'm just going to wear the mask on my chin, right? It's probably they pulled it down because they were waiting for me. But when they see me, I pinch my nose and I fix the mask on the kid, then they all of a sudden put their mask back on. We've not had too many people pounding, yelling, screaming personally. But I've known a lot of my friends who are physicians in different clinics where they've had those same experiences like Dr. Wiegard said, yelling, screaming, one where, cops had to be called and escorted the patient out, and I don't know if it is because of the political climate, it's become like a stance as opposed to following the science of what really works, right? And that's, my students ask me the same question where when I do my site visits for all our students who are at different clinical sites, they say that, they will hear people, some educated medical professionals at the site, saying, oh, once the election is over, we won't have to wear masks. I hope COVID ends as soon. We all want it to end, right? For safety reasons, but I don't think it has anything to do with November 3rd, not that I'm aware of, at least from a scientific perspective. So I think oftentimes people get the wires crossed, right? There's a different agenda. Now I always tell my students, stick with the science. That's what you've been trained, right? Stick with what the CDC says, stick with what the Virginia Department of Health says, because you can only answer true data and facts, right? You cannot change people's opinion in one encounter, right? You can only educate, you can only use that opportunity for giving them valid information, and then whether it impacts them or changes their opinion, that's, but I've been very fortunate. I haven't had those experiences like Dr. Wiegard, but I think it's because it's a peds clinic.
Jason, Deese, what would you say to this question of how to handle the client that's not following the safety guidelines?
Yeah, we get plenty of those. And, specifically, where I deal most of my time is with isolation and quarantine. And a lot of people kind of push the envelope a little bit. My thoughts on quarantine and isolation specifically are that, by law, at least initially, it's voluntary self-quarantine isolation. And we don't have to send them a formal letter saying you are hereby confined to your home or whatever. So there are different levels of leverage that you can use. Like generally, if they agree verbally, okay, I'll follow these instructions. You send them an email with some phone numbers and guidelines and stuff like that as well. 99% of people are going to follow that. If they don't, then, we can escalate things to a formal letter, threaten, okay, this might go up to the health commissioner in Richmond and it'll come down as a lawful order isolation, which is, can be legally challenged as well. By the time it makes it to court, you're already done with isolation. So usually just that threat does it. With college kids, I take the approach, if we're able to, and I guess with all people really, especially with quarantine, those are the people that are exposed but not tested positive. I do give them a little bit of flexibility. If you give them a tiny bit of flexibility, like you can go out for a walk or a jog or whatever, as long as you don't mix with other people. If you promise me that you're not going to mix with other people, stop and jolly act with Sally on the corner, then and then come back into your house and stay in your house after you've got some fresh air, some exercise, some mental health or whatever, then people are a lot more willing, I think, to follow the guidelines. So sometimes a little bit more lenient approach will get a better response, because then it's tolerable. 2 weeks to spend in a little dinky apartment is a long time. And especially when the weather's nice, or people that are used to getting out and doing some exercise, the safest place for them to be really is outside anyhow. If they got roommates, they aren't breathing on their roommates if they're outside, right? So those are some concessions that I do make. Even though technically the definition of quarantine is you stay on your own property, right? And for isolation, case by case. Other things, we get a lot of people breaking mask mandates, stuff like that. And those are really kind of sort of unenforceable. To be honest, we're dealing with people's goodwill to follow those things, the mask mandates and stuff like that. And the majority of people do. So I don't get bent out of shape if I see a person not wearing a mask. To be honest with you, most places where it counts are tight spaces in households and stuff like that, where you're spending extensive amount of time with people. Classrooms, maybe, workplaces where people can't space out from each other and they're forced to be next to each other for 6 or 8 hours or something like that. Then of course, yeah, they got to be wearing their masks. But Walmart, I'm not going to risk getting into fisticuffs challenging someone on their mask. Incident up in Michigan, recall early in this, the guy got shot at a dollar store or something for requesting someone wear a mask. I keep that at the front of my mind.
Yeah, in social work, we call it the right to self-determination. I see that you take all these different factors into consideration. And so a combination of all these different methods that you all are talking about, kindness, strong encouraging, using policies, guidelines, modeling, these are all methods that people can use. We have a final question, or maybe a couple final questions here. Dr. Russon may have one too, depending on our time. What is one important thing that you've done for your health during this time?
For me, it's staying active. So I am a college athlete, played college basketball. Athletics have always been a part of my life, exercise. So found a group of women we call ourselves the diehards, and we are up at 5:30 in the morning before we're all professional women who have careers, and we have stayed with each other. We, at the beginning of COVID, would run in like a box where we were 6 feet apart from everybody running outside. It was hilarious. And we keep each other accountable. And I know I have a group of women who are as crazy as I am, and we go out and we hit the pavement and we run on the track and we do these challenges together. And so for me personally, to know that's how I start my day, with these women, we bounce ideas off each other, we vent. And so my poor husband doesn't have to hear me complain all the time. I can complain to this group of women and they have my back. But to keep active and keep healthy and keep, I signed up for every virtual race you could possibly imagine so that I could just have that accountability and have that accomplishment for me where, at the end of the day, did I do my best job? Well, I hope I did, but I still got to do something for me. So making sure that I stay active, stay focused, and have a group of people that's outside of my work group that I can always go to.
So we have just about a minute left for questions before we turn it back over to Dr. Rist. But I'd like to hear from both of you about what that one thing you do for your health.
So for me, I will have to agree with Dr. Wiegard. I'm by no means a college athlete. I am not a diehard athletic person, but my husband was. So he is up at 4:30. He played football at Virginia Tech. So he's very much into athletics. So I have, through COVID, joined him in workouts 3 to 4 days a week. That's my limit. And it's been great, right? It's a bonding time for us because we're with our kids all the time, right? With remote schooling. So when we come home, we want to give our attention to the kids. So it has allowed us to bond, allow us to chat with each other. And mentally, I feel like, as Dr. Wiegard said, it gets your mind right to target your day, right? Because we know challenges are coming. It's just a matter of when in the day, right? So just gets your mind right, your health. You've taken the time to put you first. And I think oftentimes we forget to do that, right? If we say, oh, I'll take a walk later in the evening, you're exhausted by the evening, right? After you've sat through all your classes, after you've seen all your patients, after the million phone calls, you don't have time for you. It's so easy to be pushed aside. So I think targeting it first thing in the morning is always ideal.
Jason, Deese, how about for you?
Yeah, I agree. Try to get out and get some physical activity, exercise, on a daily basis as much as possible. And I try to get out with my kids and kick a soccer ball around. It's fun to share, bonding time or whatever. And beyond that, just having any type of hobby that's completely unrelated to work is always a good thing, even if you're not good at it. Just, something that can take your mind off of work, something that requires concentration enough that those intrusive thoughts of COVID can't get in there, right? So there we go.
Well, thank you so much to you all for sharing your information and for answering the questions. And Dr. Rist, we'll turn it back over to you.
Yeah, so just to end on time, I wanted to thank all of our panelists for joining us tonight, for your time here, especially on this particular night, and then knowing that all of us are busy, obviously, and in over our heads. So I appreciate you sharing this. This will be recorded, so we will be able to offer it to students and other faculty members who couldn't be here tonight. I wanted to thank our moderators. I really appreciate the time and energy you put into creating these questions and really helping us sort of tease out, as I hoped from the beginning, some of the similarities as well as differences between these professions, but also recognizing that there's a lot of similarities that or things that we can bond around. And I think, as Dr. Wiegard said, we're all in this together. And I think that's true. And as health professionals, we can join together and support each other in sort of some of these challenging times. So with that, thanks everyone for joining us. And again, thanking the panelists and the moderators, and I hope you all have a good evening. Bye.
Yeah, thanks for the opportunity, and everyone enjoy the night.
Thank you.
Bye. Nice to see everybody.
Bye-bye.
Bye now.